Like Dr. Veda, he graduated with honors from undergrad, which makes me think that I did college a little bit differently than y'all. But he went to medical school at Duke University and graduated from residency and fellowship at the Children's Hospital of Philadelphia, where he did a neuroimmunology fellowship. So he's here to talk to us today about neuroimmunology and autoimmune encephalitis, which is his area of expertise. And one other fun fact about him, he is a world-class marathon runner, and a new dad, so I'm excited for this talk.
All right, good morning, everyone. Thank you for that wonderful introduction. So yes, today I will be talking about recognition, management, and outcomes of autoimmune encephalitis in children. I don't have any disclosures. All right. So as far as objectives for this particular talk, we're going to start by defining encephalitis and autoimmune encephalitis. We'll then describe the epidemiology and clinical features. We'll review the diagnosis and management, and then we'll finish off with a discussion on prognosis and outcomes. All right, so I like to start off with a little case to kind of prime us for this topic. So meet patient PS. She is a 6-year-old previously healthy female that presented with 1 week of speech regression, decreased appetite, and malaise. So when talking with mom, the first symptom she really noticed was this speech regression. So this was a 6-year-old female talking in complete sentences, totally understandable, but her speech completely regressed. She was using one-word sentences and kind of babbling at times. Also had some nonspecific symptoms, and so mom brought her to the emergency department to be evaluated. In the ED, they did a thorough workup. They did an MRI of the brain. They actually did an LP, and they also did a UDS. Everything was negative. Everything was normal. They sent her home with the diagnosis of viral syndrome. She eventually represented due to worsening symptoms. She developed emotional lability, tantrums, and she had an event concerning for seizure. And so she was admitted to Dell Children's for further evaluation and workup. At Dell Children's, her neurology was consulted. We did an exam and noted that she had periods of confusion and agitation. We noticed that she did have that baby talk and babbling, which is unusual for a 6-year-old. She had brisk reflexes throughout and did have some troubles with performing some of the neurologic exam. We did an extensive workup on this individual. We did a serologic evaluation, including MOG antibody testing, which was negative. We performed imaging, which was all normal. And we performed an EEG, which did help. It was abnormal. There was slowing, there was epileptiform discharges, and we also captured focal seizures. We retapped her. This time we sent oligoclonal bands, which were positive. And we also sent autoimmune encephalitis testing, which came back positive for NMDA receptor antibodies. And so she was diagnosed with anti-NMDA receptor encephalitis. All right, so let's talk about the definition of encephalitis and autoimmune encephalitis. So I always like to begin this talk with just a broad definition of encephalitis in general. So encephalitis generally refers to inflammation of the brain. This typically manifests with altered mental status, with seizure, sometimes with focal neurologic deficits. When we think about encephalitis as a whole, it's important to figure out what is the cause of the encephalitis. And so traditionally, the most common cause has been infection. So various infections can cause encephalitis. Then there's this black box of unknown causes, meaning we don't know what caused the encephalitis. But then there's this third box, and that's the immune-mediated causes of encephalitis. This box is becoming increasingly recognized, and it's really important for us to be aware of these immune-mediated causes because they have specific treatments. Immunotherapy can be very effective for these kids, so it's very important to recognize immune-mediated forms of encephalitis. Okay. So autoimmune encephalitis refers to, once again, non-infectious disorders that often manifest with both limbic and extralimbic dysfunction associated with neuronal antibodies. In some cases, it can be associated with malignancy, though this is very uncommon in children. It can occur, after infection or concurrently with infection, and almost all cases have an identified antibody in the serum or CSF. As far as a little bit of a history of autoimmune encephalitis, autoimmune encephalitis was originally believed to be solely paraneoplastic, meaning it was believed to only be associated with a cancer and an onconeuronal antibody. And so in the 1960s, the first form of autoimmune encephalitis was described in a patient that had small cell lung carcinoma. in the setting of anti-Hu antibodies. Flash forward a few decades, in 2001, we identified a non-paraneoplastic form of autoimmune encephalitis in a patient that had antibodies to the voltage-gated potassium channel. And then a few years later, we discovered the NMDA receptor antibodies in a cohort of patients that had encephalitis. Since that time, due to advances in technology, we've identified many more antibodies associated with encephalitis, including MOG antibodies, GABA A, GABA B, GAD65, and glycine receptor antibodies as well. Okay, so we talked a little bit about the history. So now let's talk about epidemiology and the clinical features of autoimmune encephalitis. So you may be sitting here as a general pediatrician wondering, why do I need to know about autoimmune encephalitis? And hopefully this particular slide will illustrate why it's really important for everyone to be able to recognize this disorder in children. So the overall incidence of pediatric autoimmune encephalitis is about 1.54 per million children per year. And this incidence is increasing. It's increasing because we're able to detect these antibodies, and we're also just more aware of the disorder. And so there's this wonderful comparative population-based study, and I have a figure depicted here on this slide that demonstrates that autoimmune encephalitides have increased significantly in incidence. So they looked at 2 different decades. They looked at the decade between 1995 and 2005, and then 2005 and 2016. And they found that over these 2 decades, autoimmune encephalitides incidence rates nearly tripled. So it went from 0.4 to 1.2, and these incidence rates rival infectious causes of encephalitis. So you will see this at some point in your clinic, in the hospital, and so it's really important to be aware of this disorder. Okay, so there are many different forms of autoimmune encephalitis, the most common being NMDA receptor encephalitis. Another very common form of immune-mediated encephalitis are MOG antibody-associated disorders. And this is another increasingly recognized form of autoimmune encephalitis. And this is due to the fact that we now have a reliable cell-based assay that we can use to detect these antibodies in children. Paraneoplastic forms of autoimmune encephalitis are very uncommon, but they can occur. There is a female predominance, particularly older than the age of 10. Under the age of 10, the male-female ratio is about 1-to-1, but over 10, there is a female predominance. And this disorder predominantly affects young adults and adolescents, with about 40% of these cases being in children less than 18 years of age. Okay. So now that you know why it's important to recognize this disorder, what are the signs and symptoms that you should be looking out for? The first thing that is, I think, very important to get a history of is, did this patient have a viral prodrome? So viral prodrome is very common in kids that have NMDA receptor encephalitis. So up to 50% will have some sort of viral prodrome. After this viral prodrome, these kids will typically present with neurologic-based symptoms. This could include seizures, movement disorder. These are the 2 most common initial presenting features in young children. The movement disorders are often oral facial dyskinesias that kind of look like this. So just that kind of constant movement. It could be dystonia, it could be choreoathetosis, or it could even be tremor. And so these are things you want to ask about and look for. They're very common as the initial presenting features. You can also get behavior change as well in these kids. These symptoms will evolve very rapidly over days to weeks. So if you see the kid initially and you're not really sure, follow them closely, because they will evolve within days to weeks, and so you won't miss it if you follow them closely. To emphasize the point that children typically present with a more neurologic presentation rather than a psychiatric presentation, there was this lovely study that was performed back in 2013, I believe, that looked at a large cohort of NMDA receptor encephalitis patients, over 500 patients, 211 were children. They looked at the initial presenting features and their age. And what they found, I don't know if my cursor's working. So in kids less than 12, the predominant initial features were neurologic. So once again, they were seizure depicted in red or movement disorder depicted in orange, so predominantly neurologic. But then when you look at greater than 18, the initial symptoms are more psychiatric or behavioral. So it's just really important to remember that, in kids, it's really neurologic based as the initial presenting features. Okay. So regardless of that initial presentation, within the first month of the disease, these kids will evolve and they will develop at least 3 of the following symptoms. That includes decreased level of consciousness, psychiatric features, hypoventilation, memory disturbance, dysautonomia, and seizures. So once again, they rapidly evolve and develop these other features, and so if you follow them closely, you won't miss it. So as far as supportive findings with imaging and CSF, so neuroimaging in kids is often normal. And so 70% of kids with NMDA receptor encephalitis will have normal imaging, which is very different than in adults, where they more commonly have abnormal imaging. If there are abnormalities on imaging, it's usually within the temporal lobe or sometimes nonspecific findings. But because of this, remember that normal neuroimaging does not rule out NMDA receptor encephalitis. CSF, on the other hand, is almost always abnormal. And so 90% of these kids will have some sort of abnormality in the CSF, whether that's, a pleocytosis, so an elevated white count in their CSF, elevated protein, or positive oligoclonal bands. These are all things that could be suggestive of a neuroinflammatory disorder. However, there is a small proportion of these kids that will have normal CSF as well. And so normal CSF does not necessarily rule out NMDA receptor encephalitis. EEG is another really important tool to utilize. The majority of these kids will have abnormalities on their EEG. You can have some nonspecific findings, but more commonly you'll see epileptiform discharges or seizures. Occasionally you'll find extreme delta brush, which is uncommon in kids, a little bit more common in adults. But if you do see extreme delta brush, that is usually associated with a more prolonged illness. And so on this EEG here is an example of extreme delta brush, which is essentially these slow delta waves with the overriding fast beta activity. That's kind of like the pathognomonic finding in NMDA receptor encephalitis. Okay. All right, so let's review the diagnosis and management of autoimmune encephalitis. So when should you suspect autoimmune encephalitis or NMDA receptor encephalitis? So the classic presentation, and I apologize, this is small writing, but the classic presentation is an acute to subacute onset of, once again, those neurologic symptoms, seizure, movement disorder, with some sort of behavioral change. That's the classic presentation. And so any kid that has that classic presentation, they should be referred to the emergency department for urgent neurologic evaluation and management. Now, what you may see a little bit more commonly are these cases that aren't slam dunk autoimmune encephalitis. And so some examples could be a kid that presents with 6 months of symptoms or a year worth of progressive symptoms, or maybe a kid that has a known psychiatric history that has worsening of their psychiatric disorder, or a kid for seizure of life. So all of these scenarios are scenarios that you can work up in the outpatient setting, whether you want to take charge of sending some diagnostic studies or referring to neurology in the outpatient setting. And so these cases, you really need to consider alternate diagnoses. Could this be an infection? Could this be a psych disorder or drug intoxication? And then consider outpatient workup or referring to us in the outpatient setting. So what outpatient workup could you potentially pursue? So some things you can consider would be an MRI of the brain. Once again, this can be normal in NMDA receptor encephalitis, but maybe you'll be able to rule something else out, a tumor or stroke, or maybe you do see some abnormalities in the temporal lobe. An EEG can be helpful depending on their initial presentation. Ruling out infection, ruling out rheumatologic disorders or toxic metabolic causes. All of this can be done in the outpatient setting by pediatricians or providers in the community. The other thing that can be helpful is sending the serum autoimmune encephalopathy panel to Mayo Clinic. And I use Mayo because it's a validated assay. It's a cell-based assay, and it's very reliable. Now, it's non-invasive because it's serum. However, it's not as sensitive as the CSF, but it's a good first pass. If you're very concerned, you can always send that. Okay, so the differential diagnosis for NMDA receptor encephalitis is extremely broad, but it's important to rule out the life-threatening causes of life-threatening etiologies such as infection, vascular etiologies like stroke, and then structural things like tumor or hydrocephalus. But it's also important to rule out psychiatric disorders and other neuroinflammatory conditions, toxic metabolic causes, and epileptic syndromes as well. So we have a lot of tools in our toolbox, which I already mentioned on previous slides, but essentially we can do serologic evaluation, once again, mostly to rule out infection and toxic metabolic etiologies. CSF can be utilized in patients that we have a very high suspicion for NMDA receptor encephalitis. Sending the autoimmune encephalopathy panel from the CSF is the gold standard, and it's the most sensitive testing for NMDA receptor encephalitis. We can use neuroimaging to help rule out other causes, and then EEG is another powerful tool. So to make that diagnosis of NMDA receptor encephalitis, the other thing is to consider cancer screening in patients where you have a high suspicion for NMDA receptor encephalitis. That's also very important. So in order to make that diagnosis, you essentially need three things. You need an appropriate clinical presentation, you need positive antibody testing in the serum or the CSF, and you need to make sure that you rule out other causes. Once you have the diagnosis, then you need to start treatment. I will preface this by saying that the antibody panel does take 7 to 10 days. So in my practice, I don't wait for the antibodies to come back. So if I have an extreme, or if I have a very high clinical suspicion for NMDA receptor encephalitis, I will initiate treatment right from the get-go. And in those kids, that would be the classic presentation. They have, new onset seizure, movement disorder, behavior change, they're encephalopathic. I start treatment immediately and don't wait for those antibodies to return. Okay, so what are our acute treatment options? So we have IV steroids, IVIG, and plasmapheresis. This is kind of the big three as far as acute immunotherapy for these kids. In general, I typically use IV steroids and plasmapheresis concurrently for patients that have moderate to severe NMDA receptor encephalitis, and I use IVIG and steroids concurrently for those that have a more mild phenotype. It's important to not give IVIG before you do plasmapheresis because you'll just pherese off the IVIG, making it ineffective and wasting a lot of money. Once again, in kids with high suspicion of NMDA receptor encephalitis, you should be doing cancer screening. And if a tumor is identified, part of their acute treatment is removal of the tumor. So you have to remove the tumor or else they will not get better. The other thing that comes up very commonly is everyone worries we need to start treatment very acutely and quickly because studies have shown that early and aggressive therapy leads to better outcomes. In the studies that demonstrated this, early treatment was considered within the first month of disease. So you do have a little bit of time. So that's something important to remember. Don't feel like if you haven't started treatment within the first few days that you're behind. It's important to get those studies sent out and make sure that you have high clinical suspicion before you subject them to these immunotherapies, because as you can see, there are side effects with all of them. Okay. What about second-line therapies? So as far as second-line therapies, I typically start second-line therapies on almost all of my patients with NMDA receptor encephalitis, but the key indications would be lack of response to first-line therapy. So if you're seeing no response within a couple of days after doing steroids or plasmapheresis, severe initial presentation. So if this patient's in the ICU, they're going to get started on a second-line therapy, or if they have relapsing disease. So those are the three main indications where we would start second-line therapies on these children. What are the second-line therapies? So in general, there's monthly IVIG, rituximab, azathioprine, mycophenolate, Cytoxan, and tocilizumab. And I put them on a scale here. So in general, in very mild cases, I'll do monthly IVIG. But for moderate to severe, which is the majority of these kids, I'll usually do rituximab. And so rituximab has the most consensus to utilize in NMDA receptor encephalitis in children. There's a lot of data to support its safety and efficacy at improving outcomes and reducing relapse. And so generally, I use rituximab as my second-line therapy of choice. In kids that relapse on rituximab or are still not improving, I might add azathioprine and CellCept in addition to rituximab. And then in really severe cases, I'll do Cytoxan or tocilizumab. Okay. So I think it's important to think about outpatient management and long-term management for these kids. And so their treatment plan can be very complex, but I like to divide it into 4 domains of their care. And so the first domain is their immunotherapy. And for me, that's typically rituximab. So that's domain 1 of their therapy. Domain 2 of their management is managing their symptoms. So a lot of these kids will have had seizures or psychiatric symptoms, movement disorder. They might have sleep dysfunction, autonomic dysfunction. And so sometimes this requires medication. And so making sure that you're addressing their symptoms. The third domain is really important, and that's the collaboration between the pediatrician and between subspecialists, because these kids have very complex care, and it's good to have really good communication between everyone involved in their care. And then the final domain is surveillance, and that's their clinical surveillance over time, possibly neuroimaging surveillance over time, and then cancer surveillance over time. I typically do cancer surveillance for up to 2 years after the initial diagnosis of NMDA receptor encephalitis, because there are cases where the initial cancer screening is negative, but then you may identify an ovarian teratoma months later. And so it's important to surveil these kids. I like to do it for up to 2 years. And as far as duration of immunotherapy, I generally do 2 years, but there's no strict guidelines on exactly how long you should do that. Okay, so we'll finish off with a discussion of prognosis and outcomes. And so outcomes in autoimmune encephalitis are generally favorable, but they typically vary depending on the type of autoimmune encephalitis. So paraneoplastic limbic encephalitis, which is very uncommon in kids, usually have poor prognosis and bad outcomes. For NMDA in particular, very favorable outcomes. Usually about 80% will have near full recovery. And sometimes these kids can even continue to improve after 2 years. Relapse is uncommon, but can occur in up to 25% of patients, and there is a 5% mortality rate. So with these very complex kids with NMDA, they may have psychiatric disorder, sleep dysfunction, seizure, movement disorder, motor dysfunction, dysautonomia. And so it's really important that we partner with pediatricians to help with their care. And we rely on you all to help with, providing that continuity and care coordination, for helping us to advocate for school resources and accommodations, because a lot of these kids will have some sort of cognitive sequelae from their disorder. It's important that we keep these kids up to date on their vaccines, particularly because most of these kids will be on some sort of immunosuppressive therapy and at risk for infection. And so they do need to make sure they're up to date on their vaccines. Mental health optimization is always key, encouraging healthy lifestyle choices. Helping us to review their treatment plans is really important, and encouraging compliance. These kids will have lots of doctor's appointments, and so making sure that they have a good plan in place and that they're following up with all of their providers is really key. And then finally, helping us to screen for medication side effects and symptoms of relapses is super helpful. Okay, so back to our patient that I described at the beginning of this talk. How was she treated? So she got IV steroids for 5 days and 5 exchanges of plasmapheresis. We started her on rituximab, so she got the first 2 doses of rituximab in the hospital. She did have a lot of other symptoms associated with her autoimmune encephalitis, including seizure, for which she was started on lacosamide. She was on olanzapine for agitation and delirium, and propranolol for her dysautonomia. She did go to inpatient rehab for 3 weeks, and then I saw her 2 months post-presentation, and she was about 90% back to her neurologic baseline. And I actually saw her like 2 weeks ago, and she's completely back to baseline. So she's doing fantastic. Okay, so in summary, the big take-home points is that NMDA receptor encephalitis is not uncommon. It's the leading cause of autoimmune encephalitis in children, and you may encounter this in your clinics or in the hospital. You should consider this diagnosis, once again, in kids that present with that acute to subacute onset of neurologic symptoms and behavior change. early diagnosis and treatment is crucial for the best outcomes in these kids. Immunotherapy acutely consists of IV steroids, IVIG, or plasmapheresis, and then their second-line therapies generally are rituximab, and for very refractory cases, I'll do cyclophosphamide or tocilizumab. And then remembering their symptomatic therapies, these should be tailored to the individual patient and are very important for their overall developmental progress. And then finally, it's key to make sure we have close communication with everyone involved in their care. It just leads to the best outcome for the patient. And so that's it. So thank you for your attention, and with that, I'll take questions.
Oh, hey, thank you so much for your talk. One of the more complicated issues that comes up are children that present with kind of acute or subacute psychiatric presentations only, without seizures, movement disorders, or focal neurological deficits. What would you say is a reasonable first-line reassuring workup that this is not autoimmune encephalitis?
Yeah, this comes up all of the time. I think the key thing to always remember is acute to subacute onset, and that they will evolve within days to weeks. So if they do present with just behavior change, it's okay to watch these kids because they will evolve to develop those neurologic symptoms within days to weeks. Come back with a seizure, they'll come back with movement disorder, right? In the days to weeks, and you're not delaying therapy because once again, the studies have shown within that first month, if you get that therapy started, you're fine. But as far as like just basic workup, I think it's important to just make sure we're ruling out infection, serologic workup, considering MRI, maybe it's not invasive depending on how big of a deal that would be. It could be helpful. If there are signs of inflammation in the temporal lobe, that would raise our clinical suspicion that, oh, okay, maybe this kid needs an LP. I would not jump to an LP in that scenario. I would do non-invasive testing, serologic testing, MRI of the brain, non-invasive things, and watching closely.
You mentioned vaccination compliance. So I'm assuming that they cannot get live virus vaccines.
They can't. We recommend avoiding live vaccines. Now, the other thing about vaccines that I didn't. Here. So some frequently asked questions. So I did make a slide for this. So can my patient receive vaccines? Yes, absolutely, except live attenuated vaccines. The other thing that I wanted to point out about vaccines is that if they are on rituximab, it's important to communicate with the pediatrician with vaccines because we might want to time their vaccines a little differently so that they get the best bang for their buck on the vaccines, because rituximab is an anti-CD20 medication, suppresses B cells and antibody production. And so that can affect their response to the vaccine. And so it's helpful if, communicating with the pediatrician so we can time their vaccine in correlation with when they're getting their rituximab so that they really make those antibodies to the vaccine.
Could you clarify that a little bit more?
Sure.
The patient's getting it at your office today.
Uh-huh.
I see the patient yesterday, a week before, a week later.
Yeah, great question.
A week later, a month later, when?
It varies on the patient's disease severity, but in an ideal world, I like to give their vaccine at least 3 to 4 weeks before their rituximab dose. So that way they are at highest B cell production and making antibodies, and then you give them the vaccine, you wait 3 to 4 weeks, and then I give the rituximab and suppress their B cells. And so then their B cells are suppressed for 3 to 4 months, and so if they need another vaccine or whatever, after that time period, once again, 3 to 4 weeks before the next rituximab dose would be the ideal timing to give that vaccine so that they have the best chance to make that good immune response. Does that answer the question? Yes. Sure. Yes, sure. Any other questions? Just really quickly, some other frequently asked things. Medications that your patient should avoid. Really, it's just ketamine for sedation, and sometimes strong dopamine antagonists like Haldol can make movement disorders worse. Precautions, really just thinking about seizure precautions if your NMDA patient has seizures, and encouraging good hand hygiene if they're on an immunosuppressive therapy. Sometimes they get questioned about symptoms you should be monitoring for. Really, it's just looking out for any new acute behavior change or new onset movement disorder or breakthrough seizures. Immunotherapy side effects, most of these kids are on immunosuppressive therapy, so looking out for frequent infections. Other side effects with rituximab could be some liver dysfunction, headache, some infusion-related reactions. Resources, some really good resources here, and then you can refer to myself or Dr. Moodley. We have a clinic here at Dell Children's, and we see these kids. So.
Okay,
One last question? Sure.
Is that okay? So I have some patients where they have episodic psychiatric symptoms. And so parents are concerned that there's maybe a streptococcal related syndrome going on. And so, how do we best, is there any form of autoimmune encephalitis that is episodic or relapsing remitting? And how do you counsel these families?
Yeah, these families can be very difficult to counsel. In general, most forms of autoimmune encephalitis are rapidly progressive. It's not like MS where it's relapsing and remitting. It's very different. It's rapidly progressing. And so I try to explain that to them. As far as the question about pandas, I always tell families at this moment, we don't have evidence to suggest that pandas, that strep infections cause autoimmune encephalitis. At this time, who's to say that maybe years later we'll find that, maybe there is something to strep. But at this point, we don't have good evidence to suggest that. And so I try to frame it that way. And I try to explain to them that strep is very common. And so even though your kid has a behavior change, and you test for strep and it's positive, if you test most kids for strep, it's gonna be positive. And so it's just very common and there's no direct connection between the two things. So I try to counsel them and explain it to them that way. But I think it's important to make sure you emphasize that at this moment, we don't know, because maybe one day we do find that strep can be related to some sort of autoimmune encephalitis. But right now, there isn't clear evidence to suggest that.